I'm Dr. Paul Wang. I'm professor of medicine and bioengineering by courtesy at Stanford University School of Medicine. I'm the director of the Stanford Arrhythmia Service and cardiac electrophysiology. Yes, what we know is that despite outstanding therapeutic options, that is oral anticoagulation, which have been shown to significantly reduce the risk of stroke, the utilization of these medications remains low. Really as low as 50 or 60% of the eligible individuals get this really life-saving therapy. And so we really wanted to look at why that was, and in particular what we could do. And so for that reason, the study was designed to look from the perspective of shared decision-making. Now, shared decision-making is at this point, a well-developed field. It really looks at the interaction between the patient and the clinician as they share information and start to go through the decision-making process of what's most appropriate, what in particular aligns with the patient's preferences. That's the overriding point of view of this process. And so this study really was designed to really look at that and ask the question, how can we optimize that shared decision-making process with the thought that indeed would increase patient satisfaction, the alignment with their patient preferences of what they want to do, and ultimately a more informed process of decision-making that really is able to take both patients and clinicians together through this process. And so that's the overall arching idea and concept of why we did this study. Yes, excellent. So we looked at patients that had non-valvular atrial fibrillation. They had a CHADS-2 score of 1 or more for men, 2 or more for women, and were English and Spanish speakers. There were a number of exclusions, such as moderate to severe mitral stenosis, any absolute contraindication to anticoagulation, left atrial appendage occlusion, or another indication for anticoagulation other than atrial fibrillation. So it indeed represents the vast majority of patients that, in fact, we consider at risk. But this decision-making process is quite relevant. And so that's really the group of patients that we wanted to study. When we first embarked on this, we really wanted to make sure that we could address a number of barriers that we identified. One of the largest barriers in decision-making, we believed, and the literature supports, is really the difficulty in terms of understanding the information. And we can call that health literacy. And so the range of health literacy among our population is quite vast. And a large percentage of our population, in fact, has relatively low health literacy. And so we realized that we needed to develop tools that did not depend on significant on reading, were able to present the concepts in a very straightforward, understandable manner, and really present to the patient really what are the key elements and messages in terms that will motivate and affect their decision making. So that's the overall really arching perspective. So in our study design, we wanted to test the shared decision-making pathway that we devised to usual care, what we would say a normal interaction would be with a provider who's discussing anticoagulation. And so that it was a randomized one-to-one study. We ended up randomizing 1,001 patients at 5 different sites across the U.S. And that was really our main goal. The primary endpoint was a common measure of shared decision-making. Again, that's the perspective we came from. It's called decisional conflict score. And that is really one of the most widely used measures to look at the general quality of shared decision-making and, in fact, what the patient's opinion about the decision-making, their decision that they made would be. And so we really wanted to examine that, and our study was highly powered to identify a difference in those two groups. The key finding of our study was that we were able to demonstrate for our primary endpoint, which is the decisional conflict score at 1 month, difference between the tool intervention arm, that is our special novel shared decision-making pathway, versus usual care. And that was highly significant, p equals 0.007. So quite significant in both clinically and statistically. And so really we believe that we were able to demonstrate, unlike many other studies which have tried to look at this, we were able to demonstrate that we believe we can improve the shared decision-making process and have less so-called decisional conflict regarding the process of decision-making regarding stroke prevention and anticoagulation. Yes, great. Well, we've made our tool widely available. afibguide.com is the URL. We want people to use this. We feel we now have evidence, a randomized trial, that there may be some benefit of using this. So we would like really dissemination of this tool, and so others can use it in their patient population. So that's one of the key issues. What we don't know exactly is what are the key components in our pathway that made the difference. In other words, there are a number of different advances compared to usual care. One was the heavy use of animation, minimal use of reading, which appeals to really a low health literacy approach. And we also had a clinician guide where clinicians could, in fact, use tools, calculate the risk score, et cetera. And lastly, a worksheet which the patient could bring and discuss questions that they had with the clinician. So we used a multi-prong approach indeed, and we don't know specifically which one of those are the most impactful in making a difference. And in fact, it may be that all three together is really one of the key components. But I think we have learned that indeed an approach that has addressed low health literacy is very important, and in fact may lead to improved shared decision making. And so we think this will inform other conditions in which shared decision making has a very important role. So I think that's one of the things that we'll certainly believe that there should be more impact further. Yes, and so we want to use some of the similar techniques to look at other conditions and see whether a similar effect is seen. I think that'll be very important. We'll also want to look at further other groups. We restricted to English and Spanish speakers. It would be, I think, really important to demonstrate this in other patient populations, further under-resourced populations, particularly those with different languages and cultures. So I think those are some of the very exciting areas that we would love to see further studies investigate.